And I would also appreciate Dolores and Nacho for making it possible to have these fantastic webinars in which we exchange the ideas and work. And we will go now a little bit deeper on the need of using heart rate variability monitors like the ANI in giving opioid-free anesthesia. And uh, and we had a very good lecture first by Professor Berghese on the reason of using it to reduce the doses of the opioids. And I will show you that's also comparable. We are able now also to reduce the doses of dexmedetomidine lidocaine, as these drugs in very high doses also have their side effects. So it's not only opioid crisis, but we might also come to the dexmedetomidine crisis if we are not aware of these problems. Very short, what is opioid-free anesthesia? In the definition we take, it is no opioids used intraoperative till the end of surgery. Opioids given after the end, after wound closure, we do not call anymore opioid. We still call it opioid-free anesthesia, but it is then not an opioid-free analgesia. We explained already, as the patient is asleep, he can have no pain, but he is able to react on surgical stimuli. So we have to block these surgical stimuli, or we have to block these reactions. And these reactions are sympathetic, but also endocrinological and inflammatory. And we can block that by local regional anesthesia, as also been shown very nicely by Christian, by intravenous drugs. And in that regard, we have other drugs also than opioids to achieve that. What is the impact if we use opioid-free anesthesia? Well, we had already a lot of discussion on the disadvantages of the opioids, so I will not go over that now. But what will we discuss is three things. Is opioid-free anesthesia able to suppress sympathetic and inflammatory systems better compared to the opioids? That's a bit big questions. Allows ANI to reduce the OFA side effects like the hypotension, bradycardia, and the prolonged sedation postoperative. It means if we use a monitor, are we able to use less dexmedetomidine, lidocaine, ketamine in order to have a patient with less side effects of these drugs? And the third question also, do you need any instead of clinical parameters like tachycardia, hypertension to guarantee sufficient sympathetic and inflammatory suppression? It means, but we have seen already some examples. Is it possible that my patient has hemodynamic stable values, nevertheless is under stress? And in that regard, we will need to measure that stress, and we need also to treat that. Stress and inflammation, these seems two different things. And we all typically call stress happens when anesthesia is not deep enough. And inflammation, well, that's something that the surgeon is inducing. The more trauma he's creating, the more aggressive he is. If he's hampering the perfusion too long, if we have contamination, we will have a lot of inflammation. However, both systems are always interrogated, and it means that the sympathetic activation is modulated by the inflammation, and the inflammatory activation is modulated by the sympathetic system. So both systems are not independent. And it means that it's also the ANI, by measuring heart rate variability, that seems initially to be measuring the parasympathetic system, is also measuring the inflammation. And that's why both systems are related. So if we have a strong inflammatory reaction, we will see a higher sympathetic reaction and a lower parasympathetic system. Now, are we okay with using opioids in suppression, stress, and inflammation? Well, this is a discussion that's already going for a long time. And even a long time ago, already Khaled was showing that while sympathetic stress is a problem, it increases the risk for cardiovascular complications, increase of oxygen consumption, catabolic metabolism, hyperglycemia, and so on. And too much inappropriate inflammation also increases this risk. But the anesthesia at that time was not able to suppress that sufficiently, even a high dose of opioids. And so the name stress-free anesthesia actually is not valid. The question is, that was 1988. Today, are we able already to give stress-free anesthesia? Probably not with using very, very high doses of opioids, because we are not blocking sufficient inflammation. Now, if we look to the blocking of the autonomic activity, then dexmedetomidine, just here to compare one of the drugs we use in opioid-free, is comparable to fentanyl in blocking the autonomic activity. So they are comparable. But if you look to all inflammatory reactions, then we might see even the opposite. Morphine here is inducing the production of pro-inflammatory cytokines in mouse peritoneal macrophages, so even stimulating inflammatory reaction. So this is just the opposite. Morphine and stress, well, morphine interfering in the healing process during chronic stress. Indeed, if there is morphine, the chronic stress will be even worse and the healing will be also worse. So the inflammation will be probably also worse. So opioids don't seem to be, might be active in blocking the sympathetic reactions, but are not sufficient in blocking the inflammatory reactions. Stress inflammation is blocked by high-dose opioids. Well, here we can say severe stress period is visible when insufficient opioids are given, but inflammation is probably not reduced sufficient by opioids. We have other drugs on that. We might not think about steroids against swelling and edema. Opioids are not doing anything on that. Analgesics against postoperative pain, opioids are also not always sufficient to get that. And the question also, are there no other drugs to go against the release of the immune system markers? And in that, maybe still a lot of research is needed. But there is already some research regarding the effect of the anti-inflammatory effect of dexmedetomidine. And in many studies already has found that dexmedetomidine itself has anti-inflammatory properties itself. Same is true of lidocaine. Maybe we have to give that even in higher doses to get that real inflammatory reaction, but that could be the reason why in continuous infusion of lidocaine, like during a laparoscopy, is able to block the inflammation of the peritoneum induced by the pneumoperitoneum. We did already some time ago a randomized controlled study from opioid-free anesthesia versus opioid anesthesia. And I want to show you the data on the cortisol levels the next day, 24 hours. And you can see here that the cortisol levels were lower after opioid-free anesthesia compared to opioid anesthesia. We didn't have any measurement of how good the stress was blocked, but at that time we were using around 1 microgram per kilogram of dexmedetomidine, full loading up and then a continuous infusion of that. So we were using quite high doses of these additives to be sure to have blocked everything. Maybe it's important also in the cognitive dysfunction and that this inflammation is having an impact on the blood-brain barrier, and by that way is inducing delirium aspects. So drugs that are able to block the inflammation and to block a change in the blood-brain barrier probably can reduce the problem of delirium, and opiates again are there not in a good position. Now, in the search to include opioid from anesthesia, I might be the father, but I'm not alone. There are already people before me, just showing to Kellett, who was talking about multimodal analgesia and trying to avoid the opioids post-operative, but as he was a surgeon, had no impact on what's happening intraoperative, and that's what probably the missing part. We cannot get away from the opioids if we are still using a lot of opioids intraoperative, given the explanation of the tolerance and the hyperalgesia you have been hearing already. Actually, the first one who was really doing opioid-free anesthesia was Barry Friedberg. He was using propofol ketamine without any opioids for office-based anesthesia, primarily for a plastic surgery, but even large plastic surgery procedure. And the basic trick was in using blocking everything before surgery starts, and it means a high dose of ketamine, a relatively high dose of ketamine, 50 milligrams, and if combined with propofol, no problem with hallucinations if you stay below that level. And the second part was a very strong infiltration with a lot of lidocaine. And this is then the anti-inflammatory effect. So blocking the nociception and blocking inflammatory reaction with a lot of lidocaine, that was able to have no need of opioids intraoperative and also not postoperative. Now, the hyperalgesia made Mark Koch think about multimodal anesthesia. At that time in Europe, we didn't have available dexmedetomidine, so he went to the clonidine in very high doses, but these patients were sleeping them for 3 days. Combined then later on with lidocaine, also with some ketamine, and it was able to reduce the amount of opioids intraoperative also to zero, but still needed postoperative opioids. That was not a big problem, but the big problem was these patients were sleeping too long. I started around 2010, 2011, called it multimodal opioid-free anesthesia, in the focus of avoiding obstructive breathing. Initially also with clonidine beta blockers, but in a much reduced dosage so that these obese patients would be full awake. It was quite difficult, and it made it a lot easier once dexmedetomidine also in Europe became available. And so the first day it became available, we start using it. Initially, again, at that dose of 1 microgram per kilogram, loading up and then an infusion of that dose, as this was the dose of sedation at the ICU. But gradually we reduced this dose as we saw that there was no real need to go that high. We don't need to give sedation by dexmedetomidine. We need to block sympathetic system only. And being asleep, we can do that with fantastic other drugs. We call this a better multi-target opioid-free anesthesia because we are using more than one drug to each an effect. And in this way, we can reduce. You can use it with only dexmedetomidine. You can give full opioid-free anesthesia, but you need a high dose. You can give opioid-free only with lidocaine, only with magnesium, even at extremely high doses. But if you combine the drugs, you can drop every drug a lot lower. And in this way, we call it multi-target, because we use more than one drug for the same target. Now, we have different targets also. We have the hypnosis and the relaxation we'll talk about. It's here about the reflex depression, the depression of the sympathetic system and the inflammatory system. Now, the OFA indeed is developed, as we discussed here already, in an answer to obstructive breathing, to hyperalgesia, and to other side effects of the opioids that are still included. I will not go in detail on my protocol. You can find that on my website. I will have no time for that. Also, the postoperative phase, it's so important to continue with blocking the sympathetic system in addition with classical analgesic products. And what we do is we wait with classical analgesic products till the patient even wakes up. Because if you use your paracetamol and your NSAIDs intraoperative already, you are not able to give sufficient anymore postoperative as you are limited in the total daily dose. So we have sufficient drugs that are non-analgetics to block all reactions intraoperative. So keep your paracetamol, keep your NSAIDs and your classical analgesics for when the patient wakes up and the anesthesia is finished. Now, it's very important that you really try to reduce the amount also of dexmedetomidine. Opioid-free anesthesia actually is a dangerous technique and requires training and expertise. And you should really avoid high dose of dexmedetomidine and lidocaine. And as an example, I'm showing you here a very recent study, the POFA study, where they were comparing opioid-free anesthesia with opioid anesthesia. And they assumed to give a dose of 1 microgram per kilogram, already a high dose, loading, followed by 1 microgram per kilogram per hour infusion rate. Now, in reality, they have been given 1.2 microgram per kilogram per hour with a standard deviation of 2 micrograms per kilogram per hour. It means that for a procedure, and these procedures on average were around 4 to 5 hours, 15% of these patients, they got more than 13 microgram per kilogram dexmedetomidine, next also to lidocaine, ketamine, and the other doses. This was far, far too high. If they would have used and they had even in the protocol said we were going to use the ANI, but they didn't look to it, they didn't use it to reduce the doses. If they would have used a monitor and reduce if it was not needed, then these high doses were not required at all. And you would not have the side effects of long sedation, hypotension, bradycardia, on which even the study had to be halted. Multimodal general anesthesia. So the practice is, and there's a very nice paper showing that it's the idea of more agents at a smaller dose maximizes the desired effect while minimizing the side effects. So combine drugs, and in this way your patient will be waking up faster, less hemodynamic problems, as these drugs are not always identical in their hemodynamic effect, in their sedative effect. Now, we reacted on that, as we will call the multimodal word is not the correct word, we better use a multi-target. And the other aspect was also the whole inflammatory aspect was totally forgotten about. So actually we have to focus on that too. That's why we wrote a letter to the editor saying that it's better to change probably between to multi-target, and to think also about systemic inflammation that has to be blocked in this multi-approach. There is a value in combining drugs, and some studies already in the past have shown that if you add several drugs together and work on the lower dose, you have even a better outcome and less complications. And this has been shown already in '94 for other drugs, that if you use one or two anesthetic drugs compared to three or more drugs for the same effect, you will have less outcome. And so this principle is quite old. So it's nothing wrong to have also in the opioid-free approach trying to combine drugs and reduce these side effects of each one. So we are going from a multimodal to a multi-target. I must say in the past it was one drug having all anesthetic effects. Then we had the balanced anesthesia, one drug for each effect. We had then the multimodal, or better called multi-target, more than one drug for one effect. And so we focus on reflex depression, for which we are using now more than one drug to get there. I also want to show you here, and it's an overview of 1 hour outcome studies on opioid-free anesthesia, but it is quite interesting because in the first years, I was using dexmedetomidine loading to 1 microgram per kilogram and an infusion of 1 microgram per kilogram per hour, assuming this was really needed as we had no good value. We reduced in 2015, we went really to a multi-target approach, and I learned to use also a higher dose of ketamine before the incision. So we were able to reduce already to 0.6. We added then also the stress monitor, like the ANI, to our clinical approach in all these patients, and we were able sometimes even to go to 0.4. Sometimes we needed still 1 microgram, so we had to adapt for each patient different. And what you see is that we further improved the care. We had less problems thereafter, and very nicely shown in these 8,000 consecutive patients, bariatric patients, comparing opioid-free versus opioid anesthesia. The opioid-free, the whole group, initially at 1 microgram, 0.6, and then adapted accordingly. Nevertheless, on total, we had a dramatic reduction in complications, in readmissions, in admissions to the ICU, and in total hospital length of stay was significantly shorter, taking other factors into account like anesthesia and surgery experience. Very recently, we published another study on deep flap. Deep flap procedures, these are procedures of 6 to 8 hours long, one side or bilateral. Free flap surgery, what's very critical, and a large group of them were done opioid-free anesthesia using also a nociception monitor to be able to, and as you can see here, and I just have taken a copy out of the publication, we were admitted as follows. We started with dexmedetomidine 0.3 microgram per kilogram as a loading dose. We gave 0.1 microgram per kilogram for the induction of anesthesia, and then an infusion at only 0.1 microgram per kilogram per hour, hours long. So it means that the doses we were given was extremely low. If needed, we would increase a little bit, but most of the time it was not real that needed. We also added a bolus dose of ketamine before the incision, and that's a trick I learned from Barry Friedberg. Very important too. We were not able to give sufficient lidocaine infiltration before the procedure. That might have helped too. And we continue with an extremely low 0.05 microgram per kilogram dexmedetomidine postoperative. But this was only possible because we measure exactly what the stress of the patient is, and if needed, we'll go a little bit higher if required, or even could drop lower if there was no reaction at all. We had less complications, less nausea vomiting, shorter length of stay, so it was really fantastic, even better perfusion of the free flaps, and less flap revision and failure. So actually, the technique showed a very good improved micro-peripheral circulation. If we were using the higher dose dexmedetomidine, it was very easy to go up to 100%. On the ANI, and only on the moment like we're giving ephedrine or a drug to get the blood pressure change, you might see a drop, but that's normal because we are giving a sympathetic drug at that time. But as you can see here, sometimes that dose is even not that high. Like for this patient, we had 0.5 microgram per kilogram lean body weight total dose given. So that is not really that high. And we're even at that high level. So, but even every patient is totally different. I show you just another patient where we trying to give that same dose, but look here, we had to give 20 microgram of dex. We still had a very low ANI. We give another 10, another 20, another 10, another 10. So we see we have been giving a lot before really the ANI value was rising higher up. So in this case, the total dose was 1.1 microgram per kilogram lean body weight. So this is a quite high dose. But this was a patient that needed it, and afterwards waked up easily. And the sedation problem was not that big because he had a lot more sympathetic stress requiring more of this drug. And I think that's an important aspect. You can give everyone 1 microgram or even higher, and then you don't need to monitor anything, but you will have patients where you have really overdosed dramatically. Each patient really react different. And that's also with cortisol levels very nicely shown that there are patients with a higher risk even are reacting higher, patients with a low risk are lower. But again, in these both groups, there are dramatic differences. And so the suggestion is the reaction of your patient is so different. And so we really need to go to personalized or precision anesthesia. Medicine in the past was one dose fits all based on an average. Medicine today is personalized, but prediction based on age, weight, sex. But I think we have even to go one step further in anesthesia. It's not just only based on predictions, because also, as we know, even in a prediction based on whatever is not possible to gather everything. So actually, the anesthesia in the future should be measure effect in each person and adapt till the effect is reached or sufficiently blocked. And this is the call of just enough to do the job. And this is something we have to do for hypnosis, for muscle relaxation, but also for blocking sympathetic stress and for blocking the metabolic reactions and the inflammatory reactions. Here another example, a very good ideal condition in which the doses were not that high required, but as you see, we are not aiming anymore to go with an ANI to 100%. So I'm happy if we stay around and just above the 40. In that way, using the lowest dose possible. So in this case, we have been using here 0.6 microgram per kilogram in total of dexamethasone next to a ketamine loading dose of 50 before start of the procedure, and a lidocaine infusion here in total dose of 3.2 milligram per kilogram of the whole time. So yeah, and as you can see here, the ANI is not 100%, but we are happy with that because we have given just enough, just sufficiently. We were not able to see that on the hemodynamic reactions. Another example of insufficient block, not visible hemodynamic, nice, stable. I would say I will do nothing, but we look here, we are still too low. We added another 20 microgram and 5 minutes later, another 10 micrograms before being just high enough here, around 70, 80, that's fine, and that's enough. We don't need to go to the 100%. Here, a very low ANI with tachycardia, actually it's clear. Clinical signs are comparable to what the ANI is telling. In this situation, maybe dexamethasone will not be fast enough. You have to give morphine or opioid to give faster blocking that system because opioids are so much fast. Dexamethasone is quite slow. What we did is we're giving lidocaine, it's faster, also with an extra ketamine bolus dose, are able then to bring it up and have less reaction. Another nicely case where we see here a very low ANI value in the hemodynamics, not visible at all. We did give extra bolus dose and gradually see the ANI rising up. Now the hemodynamics is even showing some bradycardia. So this patient really needed to go that high. Not everyone needed it, but the ANI was showing that we are not suppressing sufficiently and we would have more inflammatory reaction, higher CRP levels, higher cortisol levels post-operative. So yeah, today we make titration possible. And just 3 other examples. Rapidly rising, that's what your frequency after induction, that's the ideal. So in this case, I didn't have to give anything extra and we were right in the way. This patient started already good, was high, but suddenly dropped. But could be due to vasoactive drugs. It could be also his signal quality was bad, so that's the other problem here. So don't rely always and say, oh, I have to give an extra bolus, so check the other factors. It could be a real painful stimuli from the surgeon. Another analysis rapidly rising with a maximum and reducing with the, so I was able to reduce my drip and we reduced my titration. And so we dropped down again. As you can see, we're now around 80. Very nice and in a good, efficient way. So I think it's important to gain control of the autonomic system. It's something we're very missing in anesthesia because yes, stress and inflammation is dangerous and is not blocked enough today. Each patient is different in the reaction and the dose needed to block. High dose of blocking drugs have side effects, so we might also call about the dexmedetomidine crisis, not on the long term, but this could be also problematic. Dosing based on the average patient is the past. We really have to go to personalized precision anesthesia. And like we're giving our hypnotics according to the BIS, like we're giving the muscle relaxation according to the neuromuscular transmission monitoring, I think we will have to give these drugs that block the sympathetic and inflammatory system according to our ANI measurement. So ANI confirms that OFA is possible, and that is fantastically, even with a better sympathetic inflammatory suppression, but we don't have to go that high. If you try to give the lowest dose of drugs in suppressants, then you avoid also these side effects. And that's what I really love, and that's why I've been showing the POFA study where they didn't go to a lower dose of DEX, they give it a maximum high dose. And if you try to block sufficiently the sympathetic inflammatory system, as classical parameters will not tell that. So they will not always present because also the beta blockers might hide that. That's why we need a real monitor to get there. Thank you. So remember, it's time to measure more and nobody is the average. Thank you.